Now, I know we're running behind time a bit, but the next talk, I guarantee, is worth waiting for, because Dr. Sorois is going to give a very provocative talk about the future of the next trials in coronary revascularization.
This is yours? Yeah, all right. Thank you very much. I think that Peter Capitaine asked me to talk about future trial in coronary artery bypass graft surgery and percutaneous coronary intervention. So I associate him as a co-author of this talk, being a partner in crime. This is just a short personal history of trial performed with surgeon. This is my biological age at the time of the trial, 1987 cavity trial with balloon angioplasty, kickoff meeting, Rotterdam surgical partner, Sir Magdi Yacoub, and it was published in The Lancet. Then 9 years later, ARTS 1, bare metal stent, kickoff meeting Salzburg, surgical partner Felix Unger, published in the New England Journal of Medicine. 2004, syntax trial, drug-eluting stent, kickoff meeting Frankfurt, surgical partner Friedrich Mohr and Ari Peter Capitaine. And then we'll talk a little bit about the Excel trial, kickoff meeting New York, surgical partner Ari Peter Capitaine and Joe Sabic. Improving technology of revascularization, surgical versus percutaneous. You must realize that in the Cabri trial, with 57% of two-vessel disease and 43% of three-vessel disease, the MACE difference was 32% mind. In ARTS 1, with 63% of two-vessel disease and 33% of three-vessel disease, the MACE difference was 14%. And the syntax trial, exclusively with three-vessel disease and left main, the MACE difference was 5.5%. And indeed, this 5.5% in MACE had a 95% confidence interval of 8.3%, crossing the pre-specified boundary of non-inferiority. So I've listened to Elizabeth very carefully, and the criteria for non-inferiority comparison was not met for the primary endpoint, and further comparisons for the left main and three-vessel subgroup are observational only and hypothesis generating. Now, personally, I would have awaited for a new PCI development before initiating a new surgery PCI trial. We are working on biodegradable drug-eluting stent. They exist, they are used, making huge progress, and I would use a mixture, an hybrid use of metallic drug-eluting stent and biodegradable drug-eluting stent in the next trial. We have stent on wire with very, very low profile. I would use it in the future. We have dedicated drug-eluting stent for bifurcation, bifurcated stent, if you could say. That exists. I will wait for them. And finally, we have dedicated device for total chronic occlusion. They almost exist with guidance, steering, and ablation. Now, what is the new target? The new target, believe me or not, is the left main disease. Who are the actors this time? What are the primary endpoint? What are the definition of the endpoint? What the sample size should be? What are the patient selection criteria? And how long the duration of follow-up will be? What kind of result in the previous trial has triggered the wish to design a new trial? And then we go, Elizabeth, in subgroup. This is left main, but left main with a low score, 0.32, 0 to 0.32. So we put two cohorts. So we have now 400 patients here. And that's the left main. In blue, the surgical group. In orange, the PCI group. And you see that mortality is 7.9 for surgery, 2.7 for PCI, stroke 3.3 versus 0.9, MI 3.8 versus 2.6, death, stroke, and MI 12.1% versus 6.9, and revascularization 14.3 versus 11.4. I'm not a p-valuist. I don't like subgroup. So see what happens. These things fade away and disappear. But it is an observation, and it can generate hypothesis. Now, the question is always, who are the patients in the low syntax score, main stem? You see less than 5% left main with 3-vessel disease, about 15% left main and 2-vessel disease. Left main with 1-vessel disease is a majority, 40%, and isolate left main is about 35%. On top of that, 61% of these left main are non-distal. Vice versa, if I go to the high syntax score, you see that more than 70% are left main associated with 3-vessel disease. The rest is left main with 2-vessel disease, and there is no left main isolated, and the majority, 66%, is distal. So if you go to the left main syntax score more than 33, also about 300 patients, then you see that the mortality of PCI is prohibitive, 10.4% versus 4.1, MI 8.4 versus 6.1, so death, stroke, and MI 15.6 for PCI versus 11.5, and revascularization 21.8 versus 9.2. I'm not a p-valuist, so let's fade away this p-value. Good. Now, who are the actors this time? Here we are. Joe Silvic, I repeat, a captain. David Taggart is chairing today, will chair the surgical committee. And then you have the heavyweight. You know, Michael Mack, Frederick Moore, Patrick Natav, John Puskas, Greg Smith, Daniel Nava, Paul Sergent, Mark Ruel, and Greg Fontana. If you look at the country leaders, John Puskas, David Taggart, Daniel Navia, and Mark Ruel. This is the pictures of some of them. What are the primary endpoints? Now, that has been a big discussion. But let's get back to this interview published in the New England 1 week before the publication of the paper. This is Elizabeth Nabel, interviewed by David Ellis and Tom Lee. And Dr. Lee said, now, Betsy, this trial was not funded by the National Heart, Lung, Blood Institute. This trial was funded by a manufacturer of drug-eluting stent. So one of the first things that a lot of readers do is, look, could that have influenced the design of the trial in any way? What is your comment on that? And the response of Dr. Nabel, Betsy, is, I think 2 points are salient, Tom. First, is the trial design actually stacked the cards against the PCI intervention by combining both the hard endpoint of death, MI, and stroke, and the soft endpoint, the need for revascularization, into a combined primary endpoint. If the trial design had separated those endpoints, the primary endpoint would have been equivalent, and there would have been a difference in the secondary endpoint. So in other words, the device manufacturer in some ways stacked the card against themselves. And then she said, but the second important point in this study is an example of comparative effectiveness research, which is receiving a lot of attention in Washington, D.C. these days, and Obama was already there. Comparative effectiveness research is a rigorous evaluation of 2 different types of treatment, of 2 different approaches towards the same medical condition, and evaluate the effectiveness of both of those approaches. We are going to see much more research in this area coming down the pike. But I think the industry is to be congratulated for conducting this type of heads-on comparison on the manner in which they did. And I disagree with her because, as a matter of fact, it is not the sponsor, quote unquote, who did decide on the endpoints, but it is a work team of surgeons and interventional cardiologists who decide to take 4 composite endpoints: death, stroke, MI, revascularization as the primary endpoint. And you recognize the main actors. Now, if I may do a comments, and this is a slide from my my fellows, they said that I said that at some point. I used to say in trials, there is not such a thing as a winner or a loser. It is not a game, although the statistical rules of engagement may indicate non-inferiority of superiority. The ultimate result of a good trial is always a better understanding of what we do in medicine. And if you want to have a definition of medicine in the Wikipedia, it is the art and science of healing. Now, this is the discussion in New York on July 31, and some of us were there, and there were 4 options. Primary endpoint, 2 years composite of any death, stroke, and MI. Major secondary, the above, and any revascularization at 2 years. Second option, 2 years composite of any death, stroke, MI, and revascularization. Major secondary endpoint, 2 years composite of any death, stroke, and MI. 3 years composite of any death, stroke, and MI. Major secondary, the above, and any revascularization at 3 years. And finally, 2 years composite of cardiac death, major stroke and MI, and cabbage revascularization. Now it becomes finally the number 3. What can we say about that? This is a discussion, and the minutes were collected by Marie-Angèle Morel between surgeon, and this discussion was led by Ari-Peter Kapitein on August 25th. So there is no interventional cardiologist in the room, and this is the discussion of the surgeon. Non-inferiority for PCI very likely to be met both at 2 years and 3 years for these endpoint death, stroke, and MI. That was the remark of Ari-Peter, non-inferiority for PCI, very likely to be met both at 2 and 3 years. Most probably the high-risk PCI patient will be excluded, which will make it even more likely to meet non-inferiority, either by exclusion criteria, exposing patient to an intervention believed to be inferior to current treatment is thought unethical. That was the argument of David recently at the meeting also. You remember, David?
Yes,
yeah?
yes.
Or the selection of the patient will be done by the heart team. Interventional cardiologists know the result from syntax and will try to avoid high-risk patient. That's the comment of the discussion between the surgeon, discussion led by Ari-Peter Kapitein. What are the definition of endpoint? Death, I think there is no debate, all-cause mortality. MI, probably we will use the definition of the syntax trial, although there is a universal definition of MI. Stroke is a topic. And if you look at the minutes of the last meeting in San Francisco on September 20, it was said acute focal neurological deficit of central origin lasting more than 24 hours. And then Joe said imaging should be mandated to confirm diagnosis. And it's also the position in the guideline of the neurologist. Then, if lasted more than 72 hours, imaging it become optional. And Frederick Moore said, note that it can be difficult to put this patient in an MRI. Sometimes the patient are confused in the first 72-hour post-surgery. Major stroke will be defined as modified ranking score equal to 3 or more than 3 after 7 days or at the time of hospital discharge. Action neurologists should be involved in the discussion. Then it is an interesting exchange of email between John Puskas and Greg Stone. The title of the trial is Excel, Evaluation of Science Prime versus Coronary Artery Bypass Surgery for Effectiveness of Left Main Revascularization. And John reacted immediately, dear colleagues, while Excel is a catchy and concise acronym or primary endpoint which does not include repeat revascularization cannot be said to measure effectiveness. Rather, as our discussion have repeatedly advocated, we are testing the safety of left main stenting. The choice acronym is therefore a misnomer with respect to the primary endpoint. As we contemplate the wording of future publication, we will have to clearly agree that the primary endpoint that include only MACE measures safety, not effectiveness. Language is important. Let us agree that the spin process has not already begun. Highest open. I remain sincerely yours, John. Okay. Now, the answer from Greg Stone, and I'm the more relaxed investigating all this trial. I mean, Frederick Moore can testify about that. I mean, I watch all these things I've done for 30 years, so I don't get excited. But the answer of Greg Stone was prevention of death, MI, and stroke comprise both safety and efficacy, together representing effectiveness. Certainly in the peri-procedural period, there are safety endpoints. However, as left main disease treated medically clearly is associated with long-term death and MI, which is reduced by surgery, long-term event-free survival in this condition clearly represent efficacy. The acronym is in no way a misnomer. Okay, that gives you an idea what we are doing. Now, let's be serious. What the sample size should be. We are talking about primary endpoint death, stroke, and MI. 3 years. As a matter of fact, the statistician helped us, Stuart Pocock, suggesting a median of 3 years, minimum of 2 years, 24 months accrued, 52 months total study length. And then we have a sequential non-inferiority superiority trial. That means that if this is the MACE rate of surgery at 3 years, the equivalent will go up to an hazard ratio of 1.4. So the PCI could have that number, let's say, multiplied by 1.4. And you see that as a function of the MACE rate in surgery, the power will increase if the MACE rate increase. Then for superiority, that's a totally different ballgame. We will assume that the surgeon have a rate of 13% and then a 30% reduction by PCI, that's suggested by the surgeon. That will be a hazard ratio of 0.7, and then the hazard ratio is going down as the number of MACE in the surgical group increase. That's a little bit where we are today. Now, what are the patient selection criteria? On one hand, there was people advocating formal inclusion criteria, left main, isolate, distal versus non-distal, plus minus 1, 2, 3 vessel disease with CTO and other bifurcation. I think it will not work. We could have a formal inclusion criteria based on syntax score less than 33. The problem is that syntax score is a European concept, and looking to Michael Mack, and is not necessarily embraced by US and Asian Pacific, let's put that way, for the time being. And it is also associated to a corporation, Boston Scientific, which makes the thing a little bit more complicated. Then maybe the compromise will be no formal inclusion-exclusion criteria, like Advocate for Arts by Frederick Moore, an all-comer approach, and there will be the patient will be quote-unquote select for randomization by an educated heart team aware of the 2 years result of syntax study based on syntax score. And of course, we will document the syntax score pre-randomization. This is one of my last slides. It goes along the line described by Frederick Moore. This is going to be published this week in Circulation by the group of Bernard de Bruyn. This is all main stem. Now let's go through this diagram. You have on the vertical axis the diameter stenosis, not visual, mind, by QCA. You see it doesn't go above 70%. 70% diameter stenosis by QCA is extremely severe. That's mean a vessel of stenosis of 0.6 millimeter. And then you see the FFR, let's say pressure gradient during maximal hyperemia. You should sell that way, Frederick. Pressure gradient during maximal hyperemia. And you see here a lot of main stem by the referring physician sent to surgery or PCI in Aalst who have no pressure gradient during maximal hyperemia. They are, of course, below 50, but they were referred for surgery. And I think Fred is right. If you put a radio in these patients who have a flow of 250 ml to their main stem at rest, you will be in trouble. Then you see here patient with even more than 50% diameter stenosis by QC who still does not have a pressure gradient, and only what is on the left side of these 0.8 should be treated. And then you see that some of these patients have a diameter stenosis pretty low on angiography, but by physiology they should be treated. So this is a very strong argument to say that we should do some physiological measurement before putting the patient on the table. It doesn't matter which table, but on the table. So I'm finishing how long the duration of follow-up will be. Ideally, from surgeon point of view, 5 or 10 years. I think it's conservative, I would say forever. In reality, it will be 1, 3 to 5 years. Why? Because the internal mammary artery is a divine. When I mean divine, has been given by God to the surgeon. We all agree about that. Is a divine, eternal vascular conduit given for free. You don't have to pay for it. While PCI devices are just human products in permanent metamorphosis. So it is a moving target. And you know, the industry doesn't like the moving target. So for marketing reason, the follow-up should be rather short, since current device will become soon obsolete. Moving target. Conclusion, I have no conclusion. I think it's right to open or reopen the discussion. Thank you very much.
If I could ask the panelists all to come up here, please. I know we're running slightly behind time, but the issues discussed today are of crucial importance to us all in this room, so I think it's probably worth spending a little bit of time with open discussion. We will take some questions from the floor, but can I just ask everyone in the room a simple question? Has anyone or who in this room feel that the current results of Syntax have already impacted on their practice, either in the way patients are referred for surgery or the nature of the disease in patients being referred for surgery? Has anyone seen a change in their practice locally? So maybe about a third of the audience. And just to follow on, who would expect, as the 2-year results of Syntax emerge into the wider domain, who would anticipate that they will see changes in practice? So more people would expect, as these results emerge, to see changes in practice. If I may, I would like just to start and ask the panel, do they feel that with the incidence of stroke observed in the cabbage arm of Syntax, is there now a mandate to be referring, the general recommendation, I should say, that off-pump surgery is what we should all be striving for in our routine practice? Peter, could you tell me what you think?
Well, 15% of the patients in Syntax were operated off-pump. And so it's not a large subgroup. So to draw conclusions from that might be difficult. Of course, you could see from the slides from which Michael Mack presented, there was only one stroke in the off-pump group. So there is an indication that that might prevent strokes. So,
okay. I will come to the cardiologist last, but Michael, let me ask the sergeants first. What is your view? Can we now make a general recommendation we should be aiming for as much off-pump surgery as possible?
So first of all, I think that a stroke rate of virtually zero in cabbage is achievable and should be our goal. And shame on us if we don't get there. It should be the same as PCI, which is 0.22% in a wide database. Secondly, I think that to ignore the evidence in off-pump surgery is not seeing, is seeing what you want to see and not seeing what it really is. But there's always a concern when you get a surgeon out of their comfort zone doing something else, you'll have worse outcomes rather than better outcomes. My realistic recommendation would be in a high-risk patient, and that high-risk patient is anybody who's elderly with significant peripheral vascular disease that we know is a surrogate for cerebral vascular disease, that patient should have off-pump surgery and should avoid the aorta as much as possible. And the surgeon should feel comfortable enough that he or she is comfortable doing off-pump surgery in the patient that really needs it. That would be my recommendation.
And Fred, what's your view?
Now, I had this view before the syntax trial, and Peter and me put every effort into writing that down into the protocol, and actually we talked to almost every surgical site to follow this. The real world is not like we want it to be, and Paul and me, we just talked about it in between. It must be our major effort to change the quality of CABG, especially in that perspective, not only in terms of using more arterial grafts, but to really control the stroke complication.
Okay, can I ask Dr. Saraz then this question? Seeing the results you've seen from syntax, if you had a patient whom you were deciding to refer for CABG, would you now take into consideration in your referral that Sergeant A would do the case off pump and Sergeant B would do it on pump, or would you say there's not enough evidence to influence you yet?
No, obviously there is a center which are better with off-pump. I mean, clearly there are differences. I mean, during the last two trials, I mean, in ARTS 1 and in syntax, there was already at the time of ARTS 1 some discussion about off-pump. The reality is that I think Fred did his best at the time of syntax to select his partner. He was very active on that, and it ended up with 15%. It ended up with 15% off pump. That's the reality. So I'm looking forward to see what is the next percentage of pump, and certainly, and you have this huge collection of 100,000 patients off pump on pump, with a difference of 0.7% in mortality, mainly due to a stroke, which is in favor of off pump, but it is difficult.
But let me ask you the question just now. Would it currently influence your decision on how you refer a patient? You personally, having a patient to refer to CABG, would you now say, I will preferentially refer the patient to a competent off-pump surgeon, or you're not at that stage yet?
I will respond to this question, and Ari Peter can testify that we never discuss stroke when we discuss bypass surgery. That's amazing, but we never do.
Okay, thank you. I know we're under now pressure to keep this meeting going as long as possible, but I'm still going to actually try and wind it up. But before we do so, let's have a couple of questions from the floor.
David, I'm sorry, we have to end because we're half an hour late, and the next symposium people are waiting outside. So, unfortunately,
I'm sorry.
Have to wrap up. No.
Can I congratulate all the presenters on a truly outstanding session?
So we got to go to another room. I don't know where. Great job.
Fantastic.
I just got to ask you a question because back in 1998,
I had a hard time. Weet je wat, nou waar staat? Wat dan? Begint gewoon 1, 2, 3, 4. Ja, die moet dan het podium of
Moeten er 3 staan of 4?
Michel, de oproep aan sprekers een stoel te krijgen die binnen. Michel?
Dat is hier.
De Maas marcheert het hier op? Anders moet je...
Ligt 4 daar, hè?
2. Sorry? No, we don't. Yeah, okay. 1, 2. But it should be. No, I'm not. I'm just talking now. So the people are sitting here and they are talking. So it's going to be like this. Talking, so everybody should hear it. Yeah, but. Yeah, no, are you going to use them?
Ja, maar achter de events kan ze nog zien of alles toekomt.
Ja.
Ik zei wel af.
Heb je een frame gaat nemen van 4 dan?
Ja, doe maar. Dus sprekersstoelten zou moeten werken.
Can we use this one?
Hallo. Ja, staat weer alle open, hè?
Because otherwise we have the same problem like yesterday. Or we use these ones. These ones will be ordered.
Zo dat het gestuurd wordt.
It was different than yesterday. Yes, the headset. You can wire the people?
We zien de microfoon komt niet weg.
Wat?
Wat?
So we need to wire.
Krijg hij 2, 3, 4 aan het sprekersstoel al binnen, ja.
That's all the mics here.
Welke nog niet? Maar de rest wel.
Ja,
for the 2 o'clock, not now.
Only this session in the moment.
Je moet een andere maas krijgen.
Ja.
I think around 1, 2, 3, 4, 5.
heel goed. Ja.
Dat is toch een answer. Dat is toch een answer.
We need to check the audio, but for the rest...
You have a seat plan?
Sorry?
You have a plan?
They can choose where they want. Okay, I will decide. Okay. Okay. Who's going to first speaker? Which one is it? It's in
The first speaker, the second speaker.
Yeah. No, it's not. They're talking in between, so you should follow. But okay, whatever is fine. No. Just you sit on this one. So with the it's not that productie
sides of the speakers. So, do we see the screens?
How is that working? So, how is that going to work then?
Oh, you just use the mouse if you want. No, you should.
Not use the...
No. But right now, this is what the people also see. So you should push F5 to have a... So it should be like this. And then you just advance like you used to just by clicking the mouse.
Because I have it here, I can read it.
Yeah, we couldn't get it to work, the script view. There's a bug in the PowerPoint. Very sorry about that.
No, that's fine. That's fine. But we don't have it here.
No, you have it there.
Not have it there. Yeah.
What have we on? Pointer?
Just a second.
No, I don't know. Yes, that's the second speaker.
I'm the first. I'm the first.
You're the first speaker. No, Mark's the first.
Yes, is the chairman. That's sense.
Ich muss mal schauen, wie das Headset jetzt sorry? So ist es sehr gut. Okay.
Yeah? Is it okay? How is it? Yeah?
Yeah, it's okay.
Yeah, good.
So this is going to work. I just moved from here, but
And then you go to your next first slide every time.
okay. It's okay. It's okay.
Slide full screen.
Yeah.
Put your first slide for you.
Good. Thank you very much. So I'm not going to use this one? I don't use this one or... Spare. Okay. As usual.
I have to follow.
Can we have the glass of water?
Well, I think we
Maar ik zie daar waar we zijn. Is het goed zo?
Hopefully.
Hopefully. Do the mics work? Because we didn't check them.
You didn't check the mic?
Your earpiece.
Yes. 1, 2, 3. 1, 2, 3. Mayday, mayday. Doesn't work.
Yeah, but he hears it over there.
Okay. Can you hear me? Yeah. 1, 2, 3. 1, 2, 3.
1, 2, 3. 1, 2, 3.
Yes. 1, 2, 3. It's fine.
1, 2, 3. No, it's not.
Here you have. It's working. 1, 2, 3.
Okay.
Okay. 1, 2, 3. Yeah.
Yeah, 1, 1, 2, 3. 1, 2, 3. 1, 2, 1, 2, 3.
So, questo qua non
Cacchio di cosa? So, ho la testa mal formata. Check the mic, please.
Maybe I have too big head or what? Because when I turn, you see when I turn it's going up.
Back and so on.
Here.
But if I turn it moves. Is there a way we can fix it?
To be honest, I don't need the computer at all.
Oh yeah. If it works, it's perfect.
It's too yeah, I cannot move my head. Okay. So, I think we have to start, otherwise we will not be able to finish. Sorry?
2 minutes.
You are the boss. 2 minutes.
Can I just go in the
Sure. Okay. Oh, okay. Thank you very much. Okay, dear friends, dear colleagues, I hope all friends, welcome to the session which is going to be devoted to the future of mitral surgery. As you are very well aware, for the past 2 years there has been a tremendous focus on percutaneous aortic valve surgery. While in the mitral field, I would say that everything remained more or less stable. There is no doubt that changes will come to this field soon. Our intention is therefore to review the current best practices as well as what a surgeon should know and do today to harvest the benefits when change happens tomorrow. And this is the main intention of this meeting. Of course, this is a very wide topic, and we thought this would not fit with the normal format of the meetings we are used to have for lunch. And we have prepared in a different way, trying to have a broader perspective. And we have today here a panel of experts. We spent together quite a lot of time, even during the middle of the summer, trying to prepare something better for you. We asked ourselves the same questions we will try to answer in front of you today. Allow me then to thank our outstanding panel of experts for the additional time and the effort they put into this new format, and we'll introduce them before we start. We have, before of anybody, Professor Griccioni. Francesco is a very well-known cardiologist. He has been working at the Mayo Clinic. You may read his name in many of the most important papers in mitral disease. He's today working in Santa Ursula in Bologna, and we are really very proud and very happy to have him here in the panel. Professor Robert Clouds, he has been working in Leiden for quite a few years. He is today the chief of the department of the Leiden University Medical Center since not too many months, or just 1 year and a half, maybe. And I think he has a lot of knowledge on mitral repair and mitral surgery, and I thank him also very much. Professor Reinhard Moyle, he is a cardiovascular surgeon also working here in Vienna in the Hitzinger General Hospital. He has been also a very active surgeon in the mitral surgery, and he is also an expert in minimally invasive surgery. And I think it's going to be important to know what he feels about our profession, our specialty in the near future. And finally, we have again Professor Mauro Rinaldi. Mauro Rinaldi has been working in Pavia for many years with Professor Vigano, very well known of all of you, and recently he also moved to Turin, in northern Italy, where he is the boss at the St. Giovanni Battista Hospital. So he is also very well known. They have a lot of experience also in mitral repair and in minimally invasive surgery. So I think with all of them we can do a very good session. Of course, the first topic that comes to my mind when talking about mitral surgery is, is it something which is going to be increased in the future? We are going to have less mitral diseases? And I would like to ask Francesco Grigioni, can you tell us a little bit about what is going to be the incidence, the prevalence, and especially the trends in the mitral regurgitation disease?
Thank you, Jose Luis. I think we should go home today with a very clear message. This message is that mitral regurgitation is a major health care problem, and we have data can prove that. This happens because what we know is that mitral regurgitation is the most frequent valvular disease in the United States and the second most common form of valve disease requiring surgery in Europe. Nevertheless, the picture out there can be even worse, because we know from population-based studies and from registries like the European Heart Survey that many patients with mitral regurgitation are underdiagnosed and undertreated. You can see here in this cartoon that out of 20% of the patients who have a clear diagnosis of severe mitral regurgitation and who, according to guidelines, should be operated on because of symptoms, left ventricular dysfunction, or both, actually are not treated. And it's always difficult to predict what's going to happen in the future. But we have to consider that due to the aging of the population, of the general population, and the reduced mortality from acute cardiovascular events, all of the PCIs we perform, the ICDs we implant, the prevalence of both organic MR and functional MR is expected to further increase.
Well, Francesco, you have mentioned that functional MR has been underdiagnosed and undertreated. According to your experience, Robert, what should be the right approach of the surgeons to address this issue?
Jose Luis, thank you very much for your question. Before answering your question, I think we should address three issues. First of all, what is the scope of the problem? Second, how can we treat ischemic mitral regurgitation? And third, what did we found in Leiden and what can we conclude from that? But first we need to define what is ischemic mitral regurgitation. It's always a difficult issue what exactly is ischemic mitral and what is functional mitral. I think functional mitral regurgitation is everything that is a mitral regurgitation caused by a non-organic disease. But it is different in the setting of dilated cardiomyopathy than in IMR, because in cardiomyopathy it's always a dilated ventricle with a low ejection fraction, but in ischemic MR it can be either in a patient with heart failure and low ejection fraction, or in a patient with relatively preserved ejection fraction. What makes it even more complicated is that a localized infarct can cause mitral regurgitation, volume overload, changes in wall stress and myocardial perfusion, leading to LV remodeling and again increasing MR. But on the other hand, also generalized ischemia can cause LV remodeling and then enter this vicious circle. So there are two modes that ischemia can lead to deterioration of LV function. What about the scope of the problem? In this graph, that's from Francesco's paper, you see the survival on the left-hand side in years on the x-axis, and what's plotted here is the survival after a myocardial infarction without MR in the upper graph, and in the lower line is the survival of a myocardial infarct when you do have mitral regurgitation. And you see there's a big difference between those lines, and these patients have similar ejection fractions. So it's not that the MR is caused by a larger infarct. These patients have similar ejection fraction. And obviously, revascularization was thought to be the solution for the problem, but it's probably not. If we look at this paper from ACLOG, where they studied patients with grade 3 MR before CABG surgery, and during CABG surgery there was nothing done about the mitral valve, only CABG, then we see that if we look at post-op echoes, that only 9% of the patients resolve their MR just by CABG alone. About 50% of the patients go to grade 2, and 40% either remain in grade 3 or worsen to grade 4 MR post-operatively. So it's obvious that ischemic mitral regurgitation is not cured by CABG only. Is dyspnea always a sign of ischemia in these patients, or might dyspnea be a sign of MR in ischemic patients? That's something we should consider. And what about the patient that has persistent dyspnea after his CABG surgery and appears to have a severe mitral regurgitation? That's a nightmare of a surgery, 1 or 2 years after your CABG surgery. I've estimated that there are about 450,000 CABG procedures per year in the US, and if about 60% have some degree of MR, so it leads to 270,000 potentially patients to be screened for MR. I'm not implying that these patients should all be operated, but it's a very large population, and some of these definitely would benefit from a procedure on their mitral valve. And the treatment is simple. It's a restrictive mitral annuloplasty. It's a complete circular, semi-rigid or rigid undersized ring. And what's crucial in this treatment is that at the end of the procedure, there is not just absence of MR on TEE. There's also an adequate length of coaptation. And we found that 8 millimeters is an ideal length of coaptation at the end of the procedure and will show a durable result. And if we then, but I do not have any proof of survival benefit. There is just no data out there that can really prove that there is survival from this procedure. But if you look at most studies that show high recurrence rates, they are flawed. There has been no standard technique used, no echocardiographic endpoint, and no standard follow-up. But centers that used standardized restrictive mitral annuloplasty show durable results, and we're not the only center that has shown that. So I've tried to summarize the results from Leiden in one slide. And what you see on the left-hand side are 3 important endpoints and 2 columns. Patients were divided based on whether they had a moderately dilated left ventricle with an LV EDD of below 65 millimeters or a very enlarged left ventricle with an LV EDD of above 65. And if we look at a recurrence rate of MR, it's very low. It's 15% at 5 years. And surprisingly, it's exactly the same recurrence rate in a larger ventricle. So it probably doesn't, the ventricular size itself is not the main driver for recurrence. Second interesting endpoint is reverse remodeling. in these moderately dilated ventricles, we see sustained remodeling in most of these patients. So we can almost say that these patients are cured by just treating their ischemic MR. But in the very large ventricles, we see only that 25% of the patients show reverse remodeling. So survival as a result from that is good in the moderately dilated ventricles and bad in the very large ventricles. So I think in patients with very large ventricles, we not only have to address the mitral valve, but also the left ventricle.
That's okay. You can maybe...
That's okay. We need it there. So do I need to click to advance? Okay. So to summarize our findings, we have found these criteria for surgical treatment of ischemic MR, and there are three main issues. First of all, we have to be clear that there has to be a severe MR, and the severity grading, we use the effective regurgent orifice that has to be larger than 0.2 square centimeters, or a regurgitant volume of more than 30 mLs. If there's a doubt about the severity of the MR, we use an exercise test preoperatively or use an intraoperative loading test to see whether the mitral regurgitation increases based on this exercise or loading. Second important issue, how large is the ventricle? If the ventricle is only moderately dilated, below 65 millimeters end diastolic diameter, a restrictive mitral annuloplasty will cure this patient with a good outcome. But on the other hand, if the ventricle is much more dilated, then restrictive mitral annuloplasty alone is not enough, and we have to address the ventricle itself. And finally, we have to address all other lesions. We have to revascularize the patient, obviously. We have to pay attention to tricuspid annular diameter, and if larger than 40 millimeters, insert a tricuspid ring. And most of these patients have dysynchrony, so it's easy for surgeons to put in an LV lead at the most ideal position. And obviously most patients need an ICD after surgery.
Thank you very much, Robert. I think it was an excellent way to show us from the point of view of the surgeon. But in our practice today, before reaching the surgeon, the patient is in the hands of the cardiologist. That's how it is. Perhaps it's going to change in the near future. Francesco, in your opinion, as a cardiologist, what do you think is the right timing for an appropriate surgical treatment?
Yes, I mean, indeed, this is one of the most controversial issues. This happens because cardiac surgery, there's no doubt, is a major event in the life of the patient. And as a cardiologist, I always feel uncomfortable in advocating a treatment based on not on the maximum evidence we can have, like prospective randomized trials. But you know, tomorrow morning in our office, we have to make a decision for those patients, even though asymptomatic. And so today, I would like to share with you some points that may argue in favor of an early surgical treatment for organic mitral regurgitation. This is a paper we recently published collecting data from few European institutions, so it's a multi-center registry. And what we found is that, yes, you can treat medically those patients with severe organic mitral regurgitations, but if you look at the incidence of adverse cardiac events like atrial fibrillation, heart failure, or cardiovascular death, you achieve a rate of around 10% per year. So you have to realize that currently available treatment does not result in low rates of adverse events. The other point we want to make is that sometimes we decide to wait to recommend surgery and we think to wait forever. This is not true. These are data coming from the same paper, and you can see that in 7 or 8 years, surgery is almost unavoidable. So yes, you can wait, but only for a limited span of time. And the other point I want to make, using this data coming from the Mayo Clinic, and the paper was from my friend Christophe Triboulois, is that if you look at the post-surgical outcome, and you compare the outcome of patients with severe organic mitral regurgitation operated on when they presented with no or minimal symptoms, you can see that at 10 years, not 1 month, 10 years, their survival after surgery is exactly identical to expected survival. So what you can do actually is delete a disease, delete the consequence of a disease. And I'm not sure there are many fields in medicine, and not in cardiovascular medicine, but in medicine in general, where this kind of results can be achieved. Of course, these are data we collected with our cardiac surgeons in Bologna, Roberto Di Bartolomeo and colleagues. You should be able to repair the valve, because if you look at different endpoints, total mortality, cardiovascular death, or if you look at combined endpoints, the independent association between mitral valve repair and the better outcome is confirmed in every patient setting. And therefore, I think we can summarize the evidence we have, saying that, yes, you can candidate your center to perform surgery in asymptomatic patients with organic mitral regurgitation if and only if you can count on a reliable assessment of severity. You must be able to perform a very safe surgery. The operative mortality in the series showing beneficial effects of early surgery were 0.5, 0.3, 0.6%. And also, the last point, yes, you must repair the valve, but you must also achieve durable results.
Thank you very much. We will all agree that there is a lot of pros and cons concerning minimally invasive techniques. It's a lot of concern about all these things. Mauro, you have quite a lot of experience in these techniques. Do you think they may apply or facilitate the treatment of those asymptomatic patients?
Yes, Jose Luis. Good afternoon to everybody. Yes, I think that for us as surgeons, mini-invasive technique are a wonderful opportunity to enlarge indications, to enlarge our practice, but for the right patients and maybe for the right surgeons only. Probably we are talking here about asymptomatic patients, and probably those patients are the ideal candidates for a mini-invasive procedure because it's easier to propose to them a less traumatic approach because they are, of course, free of symptoms, and they will accept this much better than a sternotomy. This is true provided that we can show the same good results that we obtain through median sternotomy, of course. So what is minimally invasive surgery is not a picture like this, the upper left corner. Of course, this is a standard thoracotomy. But a setting like this with a very limited skin incision, no rib spreading, or very moderate rib spreading, and of course the use of a thoracoscope is something that can really reduce surgical trauma. It can minimize the disruption of the chest wall. This patient has virtually no pain. It's a platform who can provide a safe and reproducible approach to cardiopulmonary bypass and myocardial protection. And in the future, I think we could also eliminate cardiopulmonary bypass. I'm thinking about some of the apical approach we have seen with the left thoracotomy at this meeting, and maybe Robert, you will show us something afterwards. So it's a technique that can be applied to the majority of our patient and procedure, provide the same safety and efficacy as conventional cardiac surgery, and the patients are really more satisfied. Because at the end, it's all about patient satisfaction. You know, this is a kind of funny slide, and another way to define mini-invasive surgery is that type of surgery that takes away the discomfort from the patient and put it on the surgeon. Of course, do not fully agree. At the beginning, surgeons who are embarking in a mini-invasive program, at the beginning may be hard, but with the experience and with the help of the thoracoscopy system, your operation on the mitral valve is simplified. And actually, using your video assistant, you can stand aside of the patient in a very comfortable and nice position, so it's not so hard as has been told previously. Of course, there are many lessons to learn. There are many tricks and tips that we have learned in a lot of time. Of course, you have to, for instance, if you have very diseased femoral axis, do not try to push up a balloon through these femorals. Be prepared to change your strategy. Be prepared, maybe, if you want, you can cannulate the femoral artery, but use a transthoracic clamp. Or if you have the opportunity, you can also use the endodirect system with a direct aortic cannulation. So, I mean, you must master all the techniques, and to quote Denton Cooley, do not be rigid. Be ready to change your strategy and tailor the operation to the patient and not vice versa. This is the main key point for the success. Going back to your original question, is this safe and effective? In this recent year, there are coming out many reports from many centers. This is a joint experience of East Carolina and University of Pennsylvania, for instance, in which this approach, but there are many other, of course, this approach can really give a very good result, especially in the most common subset of patients. Do not forget that the majority, especially asymptomatic patient, comes to you with a P2 prolapse. And in this subset, this technique is shown to be really safe and effective. For all the patients, well, I don't know. These reports tends to depict a patient with simple mitral problem, a simple mitral regurgitation. For more complex repair, I think the use of mini-invasive surgery deserves more thoughts and maybe should be reserved really to the very, very experienced centers. Here is another point, is that as far as now what we have done in our practice is to apply the technique we have learned in sternotomy to mini-invasive surgery. I don't know if this is totally correct. Techniques evolves. Most of us has moved from the traditional quadrangular resection with a big plication of the annulus that Carpentier taught us to what Dr. Van Hermen called trapezoidal resection with a very minimal annular plication, and we have also rediscovered more recently triangular resection on the posterior leaflet. And this simplification actually works much better in mini-invasive surgery. And I think also the new techniques with neocorde, the loop technique proposed by Friedrich Mohr, can facilitate the surgical act also on the anterior leaflet, which is the big problem if you do mini-invasive surgery. And in this, in the future, I foresee a sort of standardization and simplification of technique, and this would ease up the way of mini-invasive surgery quite a lot.
Thank you very much, Reinhard. You also have some experience on minimally invasive surgery. Do you completely agree with what now our friend Mauro was saying?
In our center, we perform valve surgery through smaller access paths rather than full sternotomy in about 20% of the cases. But this is not only for cosmetic reasons and for young models, For example, older patients with osteoporosis also benefit a lot from mini-thoracotomy. The question is, may rather be how far should we push valve repair in the elderly patients? In my opinion, there are cases where the minimal surgical approach associated with a good tissue valve replacement is a valid alternative to repair in the elderly patients. And we see here very exactly in this graph that in elderly patients, valve replacement does not impact long-term survival.
Well, thank you very much. This is a very good transition to the next topic we have to deal with. During this meeting here in Vienna, we already had several papers dealing with what to do with the elderly patient, whether it is worth or not to repair or replace the valve. So there is still a controversy about that. And what is also very interesting is to see the British registry where, as you can see in the slide, today in mitral surgery, there is more than 60% of the patients are getting a mechanical valve. It's quite different of the picture we may get in the aortic position. Perhaps there are new guidelines, new techniques, or new things we should know about what to do in the mitral patient where we cannot repair the valve. Francesco, do you think the practice has changed, or should it change regarding prosthesis selection, or do you think we are well as we are?
Yes, I would like to start with a general comment, which is sometimes us as a healthcare provider, we tend to decide on behalf of the patient. And I don't think this is quite fair. I do believe that our aim should to advise him or her in order to select the most appropriate decision for her or his expectations. For example, these two patients have the same age and a similar BMI, but I would rather doubt that any person in this room would imagine that they have the same expectations. So going more into detail that what is the right prosthesis for which patient, I think we can make some comments. The first comment is that all of us is very much convinced that the use of mechanical valves is associated with a higher risk of bleeding. These are the long-term results of the VA trial, and you can see here the rates of bleeding in mechanical prosthesis, which is significantly high on the long term. And this is because even in control setting, INR is 25% of the cases out of the ideal value we would select for that particular patient. The other data I would like to provide you today come from the Mayo Clinic and the group from Maurice Serrano, and that we must be aware of the fact that the use of mechanical valves is associated with an increased risk of thromboembolic events. These are data 10 years, and you can see here the thick line of the rates of thromboembolic events in patients who did receive a mechanical valves. Conversely, if you look at the incidence of embolic events in patients who underwent mitral valve replacement with a tissue valve or repair, was significantly lower on the long term. The other important point is that when you look at the risk of ischemic strokes, you should compare with the expected risk of ischemic stroke of the general population for that particular age strata, because it's not zero the risk in the general population. And if we do this particular analysis, we will come up with the data that after 6 months, the risk of ischemic stroke in patients who underwent mitral valve repair or replacement with the tissue valves goes back to the same risk encountered in the general population, here depicted with a red line, and these data are coming from the same paper. Whereas if you look at mechanical valves, the risk of thromboembolic events remains high throughout all the follow-up. Unfortunately, we are all aware of the fact that tissue valves are associated with a higher risk of structural deteriorations, and these are again data from the VA trial, one of the only 2 randomized trials, as you all know, we have in this setting. And this prevents us sometimes from choosing a tissue valve. Nevertheless, we should not forget that the impact of structural deterioration on total mortality on the long term is not that well defined. For example, in the VA trial, the survival of patients assigned either to mechanical or tissue valves was exactly the same as 16 years, at least in mitral position. Therefore, if we, I think, try to come up with the key points, I think that all of us would agree that tissue valves are characterized by lower rates of thromboembolism and bleeding. Nevertheless, the main potential drawback of tissue valves in the mitral position and not only is structural deterioration. But the impact of structural deterioration on long-term mortality is not entirely defined. And so I think we should go back to the original concept of individualize the correct choice for that specific patient, and therefore both cardiologists and cardiac surgeons, we should be very knowledgeable about risk and benefits related to the two options.
Well, thank you very much, Francesco. But you will agree with me that, as always, the cardiologist is trying to cheat me. We were concerned about age, and you didn't even mention the word.
Yes, I did it on purpose in a sort of provocative way, and I would come back with the concept I have on the first slide of the two patients. I think age is an important factor, is a factor we want to address when we talk about the risk of reoperation, but I don't think it should be taken in a dogmatic way. I think it should be considered as an important piece of the general picture, but not as a mandatory cutoff.
Very good. Thank you very much. Well, one of the typical things we live in the normal life is that in many cases we get a patient for mitral repair or replacement, especially we cannot repair. The cardiologist says, well, just put a mechanical valve. Patient has AFib, and you say, well, maybe it's fine. We are going to use warfarin, and maybe this is the correct way to do it. But Robert, I'm sure you don't agree with this point of view.
No, Jose Luis,
why don't you share with us a little bit your point of view?
I don't think there's no good reason and no good rationale to state that if a patient is in atrial fibrillation, you should put in a mechanical valve. And I give you some arguments. The first argument is that's probably the worst argument, but it's what comes to mind first, is that you can treat atrial fibrillation by an ablation procedure during your mitral valve repair or replacement. I think it's a very good argument because it's not sure how successful your procedure is going to be, and whether you can actually take off the patient off Coumadin after an ablation procedure, even if it's successful, but maybe the atria are very enlarged and the cardiologist is not willing to take it off warfarin. But it's something to keep in mind. I think another important issue is that as age increases, and you can see here in this slide, it's a bit of old publication, but that as age increases, you see 3 age ranges, comorbidities increase. And if you go from 60 to 70 to 80th range, the number of patients with 2 or more comorbidities or diseases goes up to 60%. And as you have all these patients with warfarin and these comorbidities, that's going to be a problem. Another issue is the reliability of anticoagulation with warfarin. And what you can see in this slide is that only 30% are within the guideline INR range of 2.5 to 3.5 is mitral valve replacement group. So it means that almost 70% is out of range, which is dangerous. Another issue is that there are coming new drugs. We have always thought that atrial fibrillation is linked to warfarin, and therefore you might as well put in a mechanical valve. But if atrial fibrillation is going to be treated by other drugs that have a similar reduce of thromboembolic risk, but much less bleeding risk, then the issue becomes, is this really true? So to go to the key points. First of all, warfarin management is difficult, furthermore so at high INR levels required by mitral mechanical valves. It's much easier to manage a patient with warfarin at a low level for AF, but with the high levels for mechanical valves, it's much more difficult. 2, new drugs will likely allow AF control with lower risks. and there are probably patients that do not get any anticoagulation at all for their AF. And finally, AF surgical ablation may also reduce the need for warfarin. So I don't believe AF is a good rationale for choosing a mechanical valve.
Thank you, Robert. Well, I'm sure you sometimes have asked yourself how strange, after so many years, surgeons, industry, all together, we never thought about doing a bioprosthesis specifically for the mitral. We have been always using aortic porcine valves upside down, and well, more recently there were new designs with pericardium, but indeed was something using the concept of the aortic and put it in the mitral. I think there is now a new design. We don't have experience. I personally don't have too much experience on that, but I know Professor Model has recently published how it behaves, this new prosthesis. Can you tell us a little bit about that?
First, I like to highlight the requirements of an ideal mitral tissue valve. It should be really designed for the mitral position. And what does it mean? The ventricular projection should be minimal to prevent left ventricular outflow tract obstruction and cord entrapment when the subvalvular apparatus is restored and preserved. And this new valve on the right side here on the screen offers the lowest ventricular projection available today in tissue valves. It clearly markers the optimally straddled the left ventricular outflow tract. The sewing cuff should of course fit the mitral annulus anatomy, not the aortic one, especially with regards to posterior annulus calcification and respect of the mitral saddle shape. This valve on the right side has a saddle shape and compliant soft cuff. The valve struts should stay away from the posterior annulus from the free wall to prevent damage of the left ventricle. This valve has a tilted position which orientates the posterior strut away from the posterior left ventricular wall. Moreover, this position optimizes ventricular flow and leads to less turbulences. And last but not least, the expected durability of such a valve should match the expected life expectancy of the patient. This design of the new valve is based on the previous valve with a proven durability up to 15 years, and 20-year results are expected next year. In our hospital, we have recently concluded a study of 63 patients to assess the hemodynamic and the patient's outcomes following the implantation of this new Magna mitral tissue valve. Patients in which repair is not possible or are referred to our hospital for mitral replacement have different perioperative conditions in contrast to a typical group of patients for isolated valve repair. Here are our results. 2/3 of our patients had additional procedures: coronary bypass surgery, multi-valve surgery, 3-valve surgery. 1/3 of the patients had reoperations, even for mitral valve repair or replacement. Therefore, in this very challenging group of patients, the mortality is still high in our whole group, but as you see here on the screen, for isolated mitral valve replacement, it's only 5%. After more than 100 years of patient follow-up, we observed no event of endocarditis, no paravalvular leakage, and no structural deterioration of the valve. Only one patient after double valve replacement and who is in atrial fibrillation had a thromboembolic event. But we can observe that 4.7% of the patients have bleeding. The reason is that 2/3 of our patients with double valve replacement and atrial fibrillation are under coumarin. But maybe in the future we could lower the INR level for these patients and further reduce bleeding. Because of the special design of the valve, and here on the left side, this is not a valve after repair, this is after replacement with this valve. The special design of the valve with the low profile and less material optimizes flow, and we see a very laminar flow about between the left atrium and the left ventricle. There is no protection of the stand post in the left ventricular outflow tract, as we see in this video, with a longitudinal view over the valve, the inflow and the outflow tract of the left ventricle into the aorta. Three-dimensional echocardiography underlines the optimal orientation of the valve in comparison to the outflow tract. On the left side, we see a schematic view of what we've seen on the right side. A transapical view to the three stents of the valve, showing you the optimal orientation to the left ventricular outflow tract. The more laminar flow over the prosthesis leads to smaller transvalvular velocities and calculated gradients and optimizes flow and hemodynamics. Additionally, the design and the orientation of the valve of the prosthesis show physiological left ventricular outflow tract velocities, as we see here. The mean velocity of 1.2 meters per second is a physiological flow about the left ventricular outflow tract. Therefore, from our follow-up, we observed significant reduction of left ventricular hypertrophy and mean left ventricular mass regression. From our experience with more than 100 years of follow-up after this replacement with this new Magna mitral valve, we conclude that the design of the valve minimizes the risk of suboptimal valve orientation, and therefore it facilitates implantation, especially in minimal invasive surgery. The optimal hemodynamics of this prosthesis lead to left ventricular mass regression and decrease in New York Heart Association.
Thank you very much. I think it's very interesting. We cannot conclude more things. It's a short number of patients still and the short follow-up. Indeed, one of the drawbacks for bioprosthesis has been always durability. We have seen the picture of Dr. Grigioni before, that there was one of the limitations. And as a matter of fact, today we have to reoperate the patient with an aortic bioprosthesis. We usually tell the patient, well, the risk of reoperation is more or less the same than the primary intervention. Is fairly true for most of the cases when they don't have concomitant pathology. But it's not the same in mitral position. I wonder whether there is something new, something coming, which is going to be in the future something we have to take into consideration. Robert, I know you have quite a recent experience in a different approach. Why don't you share with us what you did in this particular patient?
Yeah, maybe, José Luis, I think make a point, because this panel is totally pushing us towards biological valves, and as you know, I little disagree on that, because I think here the problem is a balance between the risk of anticoagulation and the risk of reoperation. Of course, Robert and Francesco just covered the drawbacks of warfarin and mechanical valves. Well, I do not totally agree, but I must admit that if we use more biological valve in younger patients, you will have to face in the future more and more reoperation on the mitral valve. And as you said, reoperation on the mitral valve is not like the aortic valve, is not a joke. It carries a substantial morbidity and mortality. Here, for instance, these are the figures of the STS database. It's not a negligible mortality, almost 6% in real elective mitral surgery, 11% if you consider, more difficult cases. So it's not, one must be aware when using a biological valve that it put the patient, especially a young patient, to a certain risk of reoperation and death. And in this regard, mean-invasive technique, I think, are really safe for this surgery. Actually, it's something that we discovered later on with time. At the beginning, we were selecting very much our patient, first operation, simple cases.
But as we become experienced, we found that really these techniques are precious to approach the mitral valve in redo cases. This is the experience again, I believe, from University of Pennsylvania recently published, and you see that in a cohort of difficult patients, both mitral valve replacement and repair performed through a mini-assess port access had a very low mortality below 5%. There are other experiences published from the group of Friedrich Mohr. Some other are not published. I know the experience from Haalst. And allow me to present my own experience. Actually is on publication in a European Journal of Cardiothoracic Surgery. This is a two-center experience. My old center with Professor Vigano in Pavia and my new center here in Turin. Out of about 1,000 of cases, a large amount of them, 27%, were reoperation. And I must underline they were consecutive, unselected patient. Please concentrate on this quarter of patients, 71 very difficult cases, second, third, and fourth redo. Most of them I would not operate on in a regular sternotomy. And again, the results of this surgery is really can be better than the traditional sternotomy. Again, a mortality below 5% with a very low incidence of complication like multi-organ failure, like low cardiac output. So I strongly believe that this would be the way. And to summarize my view on that is that video-assisted mini-thoracotomy offers good results in this difficult subset of patient. We have observed, apart from the hard point, a lower mortality, which is important, shorter ICU, shorter hospital stay, less blood products used compared to operational medial sternotomy. And I think that generally speaking, mini-invasive surgery, not only port access, I'm still thinking about transapical approaches, will reduce the risk of mortality in the future in patients who need a redo for a biological valve.
Well, thank you very much, Mauro, for bringing this very interesting data to support also the data we had before. As I mentioned before, you have a very quick and very special case. I think everybody would be very happy to know about your case.
I was rightfully interrupted, but I do think it's interesting to share a case with you. I have to stress that this was an off-label use of a device, and we used it for passionate reasons. We were confronted with a 79-year-old woman which was referred to our hospital after she had an operation in our hospital a couple of years ago in 2003, had her mitral valve replaced and her aortic valve replaced, and got severe mitral regurgitation last year. But she was a fragile old lady, and her log euro score was 32. And as you can see in the right upper panel, which is a CT scan of her mitral valve, you see there's a tremendous amount of calcification that was left behind probably after the first operation. And in the lower panel, you see the echo that the leaflets are completely flail of the bioprosthesis. Well, we did not elect to reoperate this patient. She herself was also not too enthusiastic about the new operation, but we then proposed to her to put in, and that was based on our transapical experience as a valve in a valve for the aortic position, to put a transapical sapien valve into this mitral prosthesis. These are grafts from the angio that were taken during the procedure. You can see here after the deployment of the sapien valve on the left-hand side within the bioprosthesis, and on the right-hand panel you can see how the sapien sits within the three tips of the struts of the previous implanted mitral valve. This is an echo after the procedure. It shows no leak. It's a perfect position. And then a CT scan, everything went fine. She was discharged at home. She's now, I think, more than a year after the procedure. And this is a CT scan that's made about 6 months after the procedure. And you can see here how the sapien beautifully sits within the biological prosthesis, and on the right-hand side is subtracted view, and the three markers show the tips of the biological prosthesis. This is the first and only case we've done so far, but I think this is a valuable option for the future, and I hope industry will pursue this pathway.
Thank you very much, Roberto. I think it has been like a little bit of a glimpse of today's future, because we are already up there. Indeed, we are learning more and more about the possibility of working together. I personally think we have to do that. We have to work together, cardiologists and surgeons. Francesco, what is your point of view? What do you think has to be the role of a cardiologist in the mitral disease treatment?
Yes, if I have, again, to predict the future, I hope at least that in 10 years we won't talk anymore about cardiologists, cardiac surgeons, and anesthesiologists. I like to think that we should be all part of a team where everybody provides his own expertise in trying to provide the best care to a single patient. But so far, I think all of us realize that the cardiac surgeon has a central role, of course, in the time course of a patient with mitral regurgitation, since he performs the operation. But us as cardiologists, I think we can help. We can help providing a diagnosis of severe mitral regurgitation. We can help educating the patients to what are the risks and benefits, and particularly in asymptomatic patients, to me is very important not immediately to rush to surgery in the sense tomorrow morning you're going to be operated on, but instead of educating him, explaining what are the risks and benefits. And I can tell you very often the patients are much clever than we, and they come up with their own decision. And of course, together with the surgeon, we have to work on the optimal timing to define surgery at the right moment and provide a perioperative diagnostic support to helping selecting the most appropriate technique and to check with him the results. And I think what is very important is that every surgeon should expect that her or his cardiologist should provide feedback on the long term on how that particular patient is doing. And when I see those patients in my clinic, I like to send a copy of the report I do every day to my surgeons. And I think they like it very much in saying that the valve was doing okay, the patient was doing okay, the ECG had no arrhythmias, and so on. So at least this is in my mind how we can help the surgeons in this difficult pathway.
Thank you, Francesco. Robert, you have been for years in a unit which probably is one of the best units in the world for mitral repair, mitral surgery, has been led by one of the best surgeons, Robert Huon. Now you are already the chief of the unit. You have a fantastic team in cardiology, radiology, image in general, but you are young and you probably have your own ideas of how to run a new unit. Could you share with us a little bit what you have in your mind for the future?
Yes, I was very fortunate at the centers where I was trained and where I worked over the last few years, and the people I worked with. The first thing I wanted to share with you is that there is a very strong relationship between volume and outcome, and this is data from GAMI. It was published in Circulation in 2007, and it shows not only a clear relationship between volume and mortality. And on the left-hand panel, you see that the odds of death is 0.5 almost for a center to do over 140 cases of mitral valve repairs. But also on repair rate, if you look at on the right-hand graph, you see that repair rates is increasing with hospital volume and goes up to 80% if you do more than 140 procedures per year. And I'm convinced that this is also true for the individual surgical volume. And why is it so important? I think if we embark on the asymptomatic patients, and we have heard how important that is, with complex mitral pathology, I think there are three important issues that have to be addressed. And then you have the requirements you need for your center. your mortality rate in that particular patient group needs to be below 1%. Your repair rate needs to be above 99% for these patients with degenerative disease. And recurrence of mitral regurgitation of grade more than 2 should be below 1%. These are very strict requirements, and it requires an enormous infrastructure. First of all, we have to have a good TTE and TEE assessment of the valve. On TTE, we want to know how much exactly is the regurgitation. Now we can repair so many patients are referred with only limited MR, so we have to be sure that we're talking about patients with severe MR. How large is the left atrium? How large is the left ventricle? What's the tricuspid annulus diameter? Those are things I would like to know from my referring cardiologist. And then the TEE is preferably made in a center where also the patient is referred, because the cardiologists we're working with, they know exactly what I want to know. So they can make TEEs in all directions and show exactly what I need to do. Moreover, they will come to the OR and tell me not only whether the valve is patent or not, or is leaking, where it's leaking, or whether we can accept that residual regurgitation. And this is important infrastructure and working together with your referring cardiologist. Then you have to specialize your team. I think every cardiac surgeon should be able to implant a ring and do an annuloplasty. But repairing P2s, and P2s on echo can be very much more during surgery. I think P2s, you need a dedicated repair surgeon in your team. But if it's more than P2, and this is maybe only true for 10 or 20% of your patients, I think they should be referred to centers of excellence that can really not only almost promise that the valve will be repaired, but also durably repaired, which is a completely another issue. Then in the operating room, I already said that the quality of the repair is to be assessed not only on the absence of MR, but also do we need to go back and refix this valve? And this does happen quite often. I'm fortunate I have an expert cardiologist in the OR that checks my valves and also checks on the patients later, so that's an ideal situation. But if you have an anesthesiologist that's dedicated to check these valves, I think that will work too. And then the follow-up. It's essential that we know how our patients are doing late follow-up. You already talked about it, Francesco, and I think that's a crucial part of your repair program. And if you don't follow up your patients, you don't know what you're doing, and your referring cardiologists do not exactly know why they're sending their patients to you. And obviously teaching is a crucial core of this whole program, that we have to transfer knowledge from experienced surgeons to younger surgeons.
Well, thank you very much, Robert. Mauro Rinaldi has been trained in a very interesting unit in Pavia, where Vigano, who was the chief there for many years, he trained with Carpentier. He had the same classical techniques. He was using, as you mentioned before, quadrangular resection, sliding plastic, whatever. But there has been in the unit some kind of evolution. Now you are going to Turin, you are going to another place, you are going to be already setting something different, and you are more focused on minimal invasive surgery. Do you think both things are compatible? What are your plans in this sense?
No, I think that Robert has really done a nice picture of how a unit of mitral replacement repair should be built. As far as for how to build up in a new place a mini-invasive center, the advice that Robert has given us we accept, of course, but there is some peculiarity to apply for a mini-invasive center. For instance, it's even more important to build a strong team, including all our staff, anesthesiologists, perfusionists, because sometimes one can think that this type of surgery is a solo surgery. It's completely wrong. It's the opposite. You need all of them around you when you work. So this is the first point. The second point, the volume of cases. I totally agree with Robert. If you need to have a certain amount of cases, because otherwise you will never overcome the learning curve. But we have, I think, an advantage compared to traditional surgery, is that this type that you see here of vision of the mitral valve with a thoracoscope allow us to better transfer the knowledge to all the team. So despite you are embarking in a more technically difficult program, but at the same time it's easier to move your knowledge to your collaborators.
Thank you very much, Mauro. Reinhard, do you want to add something? Reinhard, do you want to add something?
Especially, you have to train the whole team, yeah? And you have to, the first time if you operate with endoscope, the whole team in the OR can view the operating field, yeah? Normally the nurse doesn't see the mitral valve, the mitral repair, and with this possibility of all the screens in the OR, everyone in the OR gets to the center of the operation, to the operating field.
Okay, thank you very much. Maybe we can have a slide to summarize a little bit a few things. I would say that as a message, we could always keep in patients' best interest everything we do. We have to remember that we have to focus our work in the patient, and this is the best and most important thing to do. Survival, it is important. We mentioned that yesterday. Morbidity is also very important. We don't want to have morbidity, but the quality of life of the patients also is very, very important. Teamwork is of paramount importance, and I think a department, a unit has to be constructed under this idea. And I think we have also, and this is an important thing, to leave your options open. You have to leave the possibilities, not close them and leave them open, and especially for the patient. The patient has to be able to do something else. So you have been hearing the panel for a while, and now it's time to questions. You have a few minutes, 10 to 15 minutes. You have questions to the panel, please. It will be extremely good. Please, go ahead.
Dr. Wala Saber, Cairo, Egypt. Thank you very much for this really useful information about mitral valve surgery. But I believe that a good surgeon has to know when to say no as well. Actually, rheumatic affection is endemic in our country, and it's quite usual to see a patient with left ventricular end-diastolic diameter about 70s or 80s, left ventricular end-systolic diameters between 40s and 50s, left atrial diameter about 10 centimeters, maybe more, with low ejection fraction like 25%. So would you please tell us when not to do surgery for mitral valve disease?
I'm sure Francisco will be delighted to tell you that.
I mean, this is a very, very important topic, and I can sort of generalize the answer. In places where you have the transplant option or where you don't have the transplant option, and also in patients for whom you may advocate that strategy and for whom you cannot. So, of course, in centers or in countries where the transplant is not available, you may push the indication for traditional surgery a little bit. In centers where you have a transplant, even though now we are running shorting of donors, so maybe we are pushing as well our indications for traditional surgery, but still we are maybe on the more safe side. I think even though we go back to the general picture that not all the patients are the same, not all of the ventricles are the same. So the first thing I would like to look at is contractile reserve. This is our first look, what we look for first. In other words, is that ventricle able to come up with something he has in the back of the reservoir or not? And if he's not, we are very reluctant to ask the patients to go for surgery. The other point is that other colleagues will comment more on the surgical techniques, but I think the choice of the annulus and something for, and now I'm talking generally, not rheumatic disease, is very important. The type of replacement is also very important for that patient, because of course they have life expectancy despite the age, the absolute age, which is very much reduced. Another thing we look at is the pulmonary vascular resistance. So not all of the ventricles are the same, not all of the pulmonary hypertensions are the same. And so if you have signs of advanced right ventricular dysfunction, we are very reluctant to operate on those patients. Whereas we are more prone, whether on pharmacological tests like phosphodiesterase inhibitors, we are able to reverse acutely the pulmonary hypertension. This is a lesson we learn from the transplant program as well. So are those the candidates? Maybe somebody else will comment also on devices to remodel the ventricles and so on. But are those the candidates for surgery? I don't think so. If you look at the guidelines, they recommend mitral valve surgery for symptomatic patients for whom you already done everything. But I think those patients actually are at high risk, and even though the operation is successful, you can improve their expected life expectancy, you can improve their expected morbidity, but you won't get any result in absolute terms as it can be called satisfactory. So again, timing of surgery is the best way of looking at it. But if you meet them, we in our department follow this algorithm.
You want to add something?
I couldn't agree more. All the surgery we do is encapsulated in a heart failure program, and no single patient will just get a mitral valve repair. If it's a heart failure patient, it will get a multimodality treatment where we treat medical treatment, biventricular ICD, and it also depends on how symptomatic is this patient from its mitral regurgitation, or is the mitral regurgitation just a side issue. What we have seen is that although patients may not live longer, they're definitely less symptomatic if you treat their mitral regurgitation if they have such a large ventricle. Also, the rate of admissions goes down if you treat their MR. But if the ventricle is that large as you described, I think you should add something to the ventricle itself, and whether it be a core cap for dilated cardiomyopathy or something in a ventricular reconstruction kind of sense when there's a big infarct or big scar in the ventricle, that really depends on the patient. And there are also patients where we think we cannot add anything. They're there. It also depends on the age, transplantation options, device options. So it's a very complex program, very intense.
Well, actually, it's harmful. I'm sorry I didn't say in my comment that most of these patients actually are teenagers, like 17s, 18s, 19s, and they are living in rural areas, so the first exposure to a center with cardiac surgery, like in this shape, you know what I mean?
Well, as I said, I think it's going to be very difficult to see all these surgical treatment options outside of the context of a true heart failure program.
More questions or comments or something you want to know? Otherwise, I think we are going to close here because it's nearly time. They have to prepare for the next session. I thank you very much all, Robert, Reinhold, Mauro, Francesco. Thank you very much. Thank you. Yes, you would like to prepare it. I wasn't preparing it. I think there was only, you took the word. I was just about to say what Edward and maybe the audience. We have to improvise. Perfect. In the program, change the slides. Was a little bit more alive than yesterday.
Yeah, yeah.